Welcome, everyone. My name is Melanie McGackin, and I am excited to host the third session of the Rutgers Community Living Education Project's Prioritizing Your Health and Well-Being webinar series. The Rutgers Community Living Education Project, also known as CLEP, is a program through the Rutgers School of Public Health. The CLEP team can serve as a bridge for self-advocates and families whose loved ones are ready to explore various community living options within the state of New Jersey. CLEP is committed to providing individual support and information surrounding community living resources for people with intellectual and/or developmental disabilities. The CLEP team's contacts will be shared at the end of today's webinar. Today's presentation, Building Connections Between Healthcare Professionals, Individuals, Families, and Support Professionals, is being presented by Dr. Jennifer LeComte, founder of the Rowan Virtua Regional Integrated Special Needs Center, along with Dr. Andrea Iannizelli, also representing the Rowan Virtua Regional Integrated Special Needs Center. Before we get started, let's go over how you can best participate in today's learning event. To access or hide the closed caption feature, please use your Zoom meeting toolbar on your screen. Click the Show Captions icon. This icon is identified by a square with the letters CC. To ensure the highest sound quality possible, all attendees will initially be muted during today's webinar. We do, however, like to keep these sessions interactive, so to ask a question to the presenters or hosts, please use the Q&A option on your screen, and to interact with the other attendees on today's session, please use the chat feature in your Zoom control panel. Topic-specific questions will be addressed as long as time allows. And for consideration to all of our attendees, we encourage you to keep questions as general as possible. On behalf of the Rutgers CLEP team, I am excited to welcome today's presenters, Dr. LeComte and Dr. Iannizelli. Welcome.
Thanks so much, Melanie. So sorry for getting started a little late, but we're excited to be here. And as Melanie said, we do want this to be interactive. So as any questions come up, I have the chat open, and Dr. Iannizelli and I will just kind of answer as we can. So we really don't mind being interrupted, whether it's through the chat or directly in the meeting. So please don't hesitate. We really want to talk about how we can build our connections between the healthcare team, the residential team, and families as transitions happen, and really make those transitions smoother. So, and you'll see that our partnership will reflect that as well. I think that's also some of the benefits of seeing it in action already. So we really don't have any disclosures.
No.
But we have people in our lives that we care about and want this partnership and these connections to be meaningful and successful. So while they don't financially impact us, I think professionally and personally, they affect us greatly. So we hope to actually have them financially be successful in the future too. But we don't need to do that right now. So we have quite a few things to talk about to kind of discuss this process and how we have families stay in medical care as their loved ones transition into a residential facility. But we want that transition to also include some strategies for how patients can be good self-managers and how they can advocate for themselves to utilize healthcare more efficiently. But then, how do each of us become an advocate on that team? So I always talk about healthcare transition in the context from pediatric to adult, but let's just really understand that we have so many transitions that our patients and our families experience as they go through touching healthcare. And so it's not just about moving from pediatric to adult, but it's about moving between systems. And, we empathize greatly with our families about that. Those transitions are difficult and challenging. And we're hoping that we can talk about how to get there. And to get there, and this actually came out of a consensus statement that internists, family medicine, and pediatricians tried to have a dialogue about how do we make this better. And a large part of that transition is how do you identify a primary care doctor? How do you find one?
Huge.
And that's the rate limiting step, because if you can't find a medical home in a primary care, then you're going to have a barrier. So Dr. Inazelli is going to talk about how do you find one.
And just so you guys know, I'm a special needs mom. So been there, done that. My son is almost 26, and so it's hard for us as families when we've been in this amazing children's system of care, CSOC, and we've got to transition out. It's like, oh gosh, I don't even know where to begin. And if you guys are like us, we weren't really given any place to go. It was kind of like, okay. And so talking to other parents was hugely important for us. Looking on social media, if you don't know of any other families to go to, that's really important. And we did ask our pediatric providers. A lot of them didn't really have great suggestions. It was really mostly talking to other parents, frankly, and word of mouth is how we personally found our providers and our family. Now, something else that is really important is a lot of people, a lot of doctors too, actually, feel like, well, you need to have a background in special needs. You have to go to a dedicated special needs center, like Risen Center. That's not true. I mean, we have great resources here for our patients, but you don't have to come to a center like Risen Center. There are a lot of doctors out there who are very comfortable dealing with special needs individuals, and they're really wonderful at it.
So this group is probably a really great resource. So put in the chat, how did you find a good primary care doctor? How did you find something, so that we can help other families who are already on this call? And listen, we learn every day from our families about a resource that we thought we were good at having resources, and every day they share that with us. So please feel free to join in the chat and share what resource made it successful for you finding a primary care doctor. So part of why you can't find a primary care doctor, and part of our opportunity as educators, because we work in a medical school and we work with resident doctors who are already chose internal medicine as their specialty, but they may go on to be to choose specialty care, is that not all of them are prepared with some of the knowledge that they need in order to incorporate patients with special needs in their practice. I think that we prepare doctors fairly well, but there are some nuances, and so that's why folks seek out this special doctor. But what we know from the research is that if we just include people with different abilities in the practices of residents and for medical students being able to participate in their care, they actually will accept patients with different abilities in their practice readily. And so we do find that it's our mission, Rowan Medicine's mission, to prepare more doctors who've experienced people with different abilities, because we know families that no one cares how much you know until they actually experience a caring doctor.
Yeah, very true. And I'm seeing some people put in the chat that their support coordinator referred them. That's amazing. If we had support coordinators referring to PCPs, that would be phenomenal. Insurance. Someone mentioned that they went to their insurance, and their insurance helped hook them up with a great PCP. Wonderful. Those are great options as well.
And then we start to, once we get involved in primary care, finding the specialist like an eye doctor can be really challenging. And so again, that's where we rely on our families to tell us who worked for you, and how did that help, and how can we get more people there? And so we're still working on building those bridges. So one of the tools that we actually brought into our students and residents is working with this photographer who developed this curriculum called Faces Redefining the Art of Medical Education. So we've started to include that in our medical students curriculum, and we find that that's been really helpful. So the next part of the transition is creating a portable medical summary.
Yeah. So, as a parent, a caregiver, the primary care doctor or the physician team, the medical team that you end up choosing is only as good as you allow them to be. And part of your role as caregiver is to empower them. And empowering them means giving them information. And I saw someone in the chat mention that it's hard finding a doctor because doctors don't want to spend a lot of time. They don't want to, go beyond that 15-minute time block that they've got to spend with you. And that's absolutely a challenge. And these next tips that we're going to give you are going to help streamline the process a little bit. So if you are able to create a portable medical summary, and that just goes with your adult child wherever they go, whenever they go to a medical appointment, and that would include having relevant information at your fingertips that the doctor or nurse practitioner or PA are going to need, including their medical history, along with dates. Like, okay, so they were diagnosed with autism, what age? They were diagnosed with OCD, what age? They were diagnosed, whatever they were diagnosed, have the date they were diagnosed with. For medical issues, psychiatric issues, any type of trauma history is really important for them to know as well. Whether they had medical trauma, whether there was any type of physical trauma, psychiatric trauma, were they bullied? That's important for the provider to know, because sometimes that plays into behaviors that your child might be having, your adult child. Allergies or adverse reactions to medications are important. If they have any special dietary needs, the doctor at the medical practice needs to know that. Like, my son's on the ketogenic diet. He can't have liquid medicines with sugar in them. That's important for the practitioner to know that. If they've had any surgeries, what are the surgeries they had? What dates did they have those surgeries? A family history, because we kind of forget with the special needs population, because we're focusing on their special needs, we forget that they also have all this other stuff. So if you've got a family history of high blood pressure, a family history of heart disease, that's relevant as well for your adult child. Bring an accurate medication list along with dosages and how often they're taking them, and know what each medication's for, because some medicines can be used for different things. So if you know what each medication's for, you can articulate that to their physicians, as well as knowing triggers. We've got patients who come into Risen Center, and something like going clearing your throat might be a trigger for them. That's important for the medical team to know, so that they avoid those triggers. So that's important as well.
And one of the challenges when our families have their loved ones transitioning to residential is that they're not coming and bringing this portable medical summary, but certainly if they also help the residential facility have access to this, and then use this, the portable medical summary, not only as an education tool for our patients, but also for the DSP worker, right? So helping the DSP worker understand your loved one, right? Using these these transition care summaries as a tool for them to get to know your loved one, so that you feel confident when they're advocating for your loved one in an office visit when you can't be there. They have an understanding, and they feel empowered to take an active role in your child's, or your son or daughter, or your adult child's life, because it's overwhelming, where they often feel like they're the driver. They just had the keys and had to make sure that the patient got here. I was a one-on-one in CHOP as a psych care provider, and I can't tell you how many times that they were rounding on the patient that I literally knew when they cleared their throat, and no one asked me. And so having families value the DSP or the group home staff as an advocate for your son or daughter, or having the patient value them as being an advocate for them. And then here's the other thing, having the physicians value it. So I can tell you that we value them highly, but I know that they didn't experience that on every one of their visits, and they didn't feel empowered to say, hey doc, can you take off your white coat? it's making them very anxious that you have your white coat on. And it was sad for me as a physician to know that that DSPs didn't feel comfortable telling a doc to take off a white coat because it made them anxious. So how using these portable medical summaries as an empowerment tool for DSPs, as well as educating our patients, because listen, I want my patient to tell me what they're allergic to, and they spend a lot of time in residential with downtime. Spend a half hour every day going over what their allergies are so that they can feel empowered to tell me when they get here. I will tell them to do homework. I'm like, you next time you come, I'm going to ask you what your allergies are. We're going to go over it a couple of times, but you're going to have to tell me, and I'm not going to allow mom to answer, and I'm not going to allow your DSP to answer. And so really empowering our patients to become their own self-advocate and using these tools.
And we know that, of course, not every special needs adult is going to be able to do this, but for the ones that are, let's give them wings to fly and take responsibility as much as they can for their own medical care.
So we have a couple of examples in here, but I think, again, this might be an opportunity where I think Melissa shared the PADS resource on here. Thank you for sharing that. That can be tools for you. So yes, this is a Canadian resource, but anyone can use it, where it's good to go transition and you can create your own health passport. Listen, our patients are way better users of technology today than I think that I ever will be. And so having them find that app that allows them to input their own data so they can learn about what they have and how they need to speak to the doctor. We'll share some other resources too and how they get there. So please feel free to share some of the resources in the chat. Like I said, I use the transition, the good to go tool, but there's probably, you all are probably using it. Actually, I should say another tool is some of your tertiary care pediatric hospitals. So when you're leaving a pediatric system and entering into adult system, some of them already have transition consultation.
Yeah.
So CHOP has one.
It's like it's long.
Yes.
But it's great. It's thorough. So if you take that with you, by the transition planning committee, or I think CHOP at least has like a committee, and they'll give you everything that any future medical provider is going to need. So.
And patients, families can ask for that consult without having another doctor do the referral for you. So thanks for sharing all that information.
Yeah, I know. I'm looking at all the comments, a ton of comments. These are.
Oh, great point. Someone brought up that insurance can also help.
Hi, Dottie.
They can also help with that transition process. They really can show you who is accepting new patients, and they have their own coordinators that help with complex care needs.
Yeah, use them as a resource. They're a wonderful resource.
Yeah, because every transition, again, every change in insurance requires a new formulary. You know, when our patients need liquid and suddenly they're 21 and for some reason they think that they don't need liquid anymore because they became an adult, you know, we need to do prior authorizations. That is all stuff that happens on the back end, and unfortunately families and group homes feel it every day when they can't get access. So having someone in the insurance as your support is also another really great way as we cross over some of the bridges that we come. And sometimes it's literally they had a formulary when they were admitted to the hospital, and you know, they're not changing providers, but as soon as they get out, they don't have access to that med anymore, and so that can be a big barrier.
Transition
Dr.
planning.
LeComp and Dr. Iannizelli.
Yeah.
We do have a question that came in that was addressing a little bit about providing a full history to someone's primary care. The question is, how do you protect the health history of parents when they have shared the information to the PCP? Often treatment summaries include the family history that is handed to a direct support professional. Some information may be important, but generally their lack of knowledge regarding medical conditions make diagnosis of parents unnecessary. Can you give some suggestions if families are handing over a medical history, how to protect that from people who are not the physician to see?
That is a great question and really insightful. So thanks
Yeah.
for actually highlighting that and bringing that to our attention. There's several HIPAA concerns that we have as patients transition to group homes. So one of the best ways is having families complete the new patient intakes and directly deliver it to the practices, and specifically say, we want part of this health information to be protected. I agree with you. DSPs don't need to have access to all of that.
Yep.
And I certainly, even in some of our patients have experienced medical trauma and unfortunately other trauma that maybe doesn't need to be brought out in an office visit with the DSP. Certainly in the way that our practice is designed, we do a 3-point touch with every new patient that can reveal some pretty sensitive information that helps us understand the patient and know how to take care of them better, but doesn't need to be shared with everyone.
Sure.
So that's the only way currently I know how to share that information.
Yeah, but you can, if there are concerns on the part of the family and they don't want that, you can specifically ask that it becomes blocked. There's
yeah.
a way to block it in our EMR system so that we can see it, but no one else can see it, and it's not going to get printed on any outgoing paperwork. So I would recommend to those families to just, pull the physician aside or the practitioner aside, or send them a message offline through the portal, or send them a letter or something. Just communicate with them and say, hey, this is sensitive to our family. We don't want this shared. Can you make sure that it's blocked and not put on any outgoing paperwork? And they absolutely have a responsibility to honor that request.
Yeah, so especially when you're talking about transition from pediatric to adult, even parents' access to the patient's information, specifically relating to STD or reproductive health or access to birth control, that information is also private to the patient and doesn't always need to be shared with the families, which can be very frustrating for families when they don't always see their adult child as being able to make those relationship choices, let's say. But we know that we want every patient to have some private time with their doctor. So the reverse side is also true. There's some information that we share, that we sit down with our patients directly and actually ask families and DSPs to leave the room. Yes, this is more challenging when our patients don't use words to communicate, but we all know that our patients and our family members communicate with us in very different ways, and we start to build those relationships. We actually can access really good, we really can get great information that both assists in their thriving in the community and not just being healthy, like actually thriving. Patients talk to us about a lot of things. So also protecting that information. So typically the way I describe it to my patients when we're alone is, we're going to have some private time to talk together. There's 3 reasons that I would share any of the information that you hold private between us, that I would share it with someone else. And those 3 reasons are, if I fear that you're going to hurt yourself, that you're going to hurt someone else, or that someone's hurting you. Those 3 reasons, I can't keep that a secret. I can't keep that private between us. And we don't like to use the word secret either, because we know that that has some pretty significant nuances in keeping our patients and families safe. So I basically say I would share that information if I was worried about those things. What a great question.
Yeah, that's a really good one.
Yeah, it really was. And we do have other questions come in, but I want to make sure that you're both getting through the general content that you were sharing. So I'll hold the other ones until the end.
Sure. So we're about halfway there, but again, we're welcome to diverge from this information. We specifically talk about transition at 14 only because our patients with different abilities have IEPs in the school system. And listen, the healthcare doesn't have such exacting dialogue in our transition model. So if that doesn't exist, then we're going to use these other transition timeframes as our help. So one of the big things is just talking about who's going to help us make medical decisions and that guardianship. So you might want to talk a little bit more about that.
Yeah. So, with regard to guardianship, it can be complex guardianship, right? Because for some individuals, it's really clear that they're not going to be able to make their own decisions. They don't have insight, they don't have good judgment. And so it's kind of a no-brainer that this particular individual needs a full guardian, and it's very clear who it's going to be. There's a family member or a close friend or someone who has a vested interest in that individual. There are other cases that aren't quite so clear, where maybe the special needs individual has a pretty high level of function. They do have good insight into what's going on with their medical issues, all of their issues, but maybe they don't always exercise good judgment. So it can become complex. Some people really don't know who should be guardian. So it's good to start thinking about these items as early as possible. And again, that's why we say starting at age 14, because for some people, it takes a few years to figure this stuff out. And 18 is the magical age where guardianship really should happen. If the individual needs a guardian, that should happen at age 18. So which means it needs to start well before that.
And then when we're talking about transition, someone also brought up that they've been able to keep their family with one doctor over generations, which is beautiful. So I'm a med peds physician, and similar to family medicine, I can take care of someone from cradle to grave, as they say. And so it's also important to note that still transitions need to happen at that time, like allowing the patient to have some private time with the doctor. So even if they have a disability, allowing those natural transitions of acquiring some autonomy, it might just be as simple as allowing your son or daughter to say their name and check in, so that they're starting to show some autonomy in different ways. A social worker I worked with years ago, her daughter was checking into her appointments at age 4. She was like the epitome of like wanting autonomy. And so it's also about having some autonomy in the home, going and allowing people to get their medications out of the, wherever they need, so that they're participating in their care. So even if you're not going to leave a provider, recognizing that there's some, I call them watershed moments in people's lives where we're starting to allow people to developmentally grow even as they graduate in a practice. So thanks for sharing that. I love that continuity between families and being able to stay within the families, because you've grown together, and I believe in that. I think we both do, because and the reality is, once you transition to adult care, you're with us a lot longer than with pediatric care.
Whether you like it or not.
Exactly that. So that's where equally supported decision making kind of comes into play. And I think in New Jersey, we're still struggling with thinking that everyone needs to kind of transition to guardianship. And maybe they don't. And I know that's really a challenging topic, especially when we're talking about having group homes and DSPs also being part of that support system, and where the trust is for that. So I don't have all the answers for that. And maybe some of the families have found some ways where they've built in DSPs as supported decision makers. But I do know, again, even if you're going to stay with the same provider, if we empower our patients to become self-determined and self-directed, that they're safer, that they have better access to care, that they're better able to speak out if someone is going to inappropriately touch them or offer them things that they really don't need. And I think what families are, I think, are always, their eyes are open when they actually see their child being able to advocate for themselves in ways that are really life-changing for them. I'm making sure I'm not missing anything, Melanie. We're looking at the chat to try to be accommodating too. So let us know if you see something that can be helpful. And we already articulated this. Basically, our patients can be healthier, more adjusted, and really we just need to get out of their way. So how do families stay partnered in medical care? Because sometimes it can feel like you're kind of battling a shark. But just know that all of us come together really to keep our patients safe. And I think that the key to this is partnership.
Yeah. And with partnership, looking at it as a triangle of respect and trust is really important. And that means the families trusting and respecting the staff that's caring for their adult child. It's respecting special needs individual and recognizing that they're adults, and sometimes they need to be given latitude to make their own decisions and to exert their wishes when it comes into planning, care planning. But then likewise, the staff respecting the family. So it's this whole, this whole circle of respect, essentially. And it goes both ways, right? Family respecting their special needs individual as an adult, and respecting the staff respecting their client and the family. And so having open lines of communication is important in this regard as well.
Yeah, and sometimes some of our partnerships don't always work, and when we find that there isn't a good fit with the primary care doctor that you chose, if you don't feel like they're listening to the patient or listening to the families, and then not advocating for the way that the families are asking for, that's when it can definitely become challenging. And sometimes that means that you do need to look for another one, which is also challenging when the group homes are the ones that need to take patients to the appointments. So, I know that can be equally challenging. Just getting an accommodating appointment, meaning that you have long enough time in an appointment to address the needs of people with disabilities, really is an accommodation, right? Yeah. So asking for that at the outset when you do join a practice, or when the residents choose a practice for your loved one, is really important. And I think that I think a lot of people don't know that they can ask for that.
Yeah.
I'm going to need a longer appointment. I'm going to need the first appointment of the day. And if you're finding that a practice can accommodate that, that is an ADA guideline, and it's not a burden, except for that our administration sometimes are asking us to see more patients. That can be challenging.
It's challenging, but also, with regard to finding an office that will accommodate you, Dr. LeCompte mentioned having a first appointment of the day. So if you ask for, hey, can I have, so that you don't have to wait as long, because we know, I get anxious when waiting for an appointment. So I can respect our special needs adults who also do. But if you have the first appointment of the day or the first appointment after lunch, those are like the two key spots that you should look for if you know that your adult child is going to have a hard time waiting. Likewise, some families prefer to ask for the last appointment of the day. That way there aren't any other patients that are waiting after them, and the doctor or nurse practitioner or PA may have more time to spend with you because you're that last person, and they don't have to stay on that strict schedule like they did earlier in the day. So those are the three key spots to look for when you call to ask for an appointment.
So I think we said this. Yeah. So one of the opportunities is having families attend the appointments. And we recognize that sometimes the appointments aren't made by, and including the families, they don't even know that there's an appointment coming up. So I will tell you that's still something that we're struggling with too. How do we identify making sure that all the players are invited, all the players in the partnership are invited to the appointment? And it's equally challenging when you spend extra time with a patient than needing to contact families and getting their input. So one thing that's worked really well with some of our patients is families actually provide that kind of ask or their want list before the appointment so that we're making sure that we incorporate it into the appointment. And knowing what the appointment's for, but again, families need to know that the appointments are being had in order to
The
be,
communication thing.
yeah, to be included in it. So, and then, you know, we do have alternate accesses, the portal system through our electronic medical records. They can sometimes become overwhelming too. So maybe setting up regular communication with the primary care doctor outside the visit, but it should be scheduled so we're respecting everyone's time, so that we're not sharing that HIPAA information of a family with a DSP. Equally, we ask our group homes to share that what they need for the visit prior to. We know that many of our state agencies require a lot of paperwork.
Yep.
I don't think there's any value in sitting in an office visit with a special needs person for an hour filling out paperwork together. So what we do is we ask for those forms in advance so that we're not spending that time, so that we're at the ready, and the only things that we have to put in are the things that are changing for that day, like the physical exam. But a medication list, unless we're updating it immensely, shouldn't change. So we should have all that stuff in advance. That's what I would encourage DSPs and our residential facilities, and I'm hoping some of them are on here, some of the leadership are on here, so that our families are actually, and our group homes are filling out the information that they know, so that we're already ready to move on to the next step.
Yeah, preparation is really important. A lot of times we'll get blank paperwork, and that's not helpful to anyone. So it's important for us to know when you come to your appointment, whether you're a parent bringing your individual or whether you're a service provider bringing your individual. We need to know things like updated medication lists. Have they had any procedures or any other doctor's appointments? Because it's important for us to know what the GI doctor said, because a lot of times we aren't getting the communications from them. You guys are. So bring that with you. That's important for us to know. When was their last BM? That's important for females. If they're menstruating, when was their last period? So things like this, like kind of, if you can't write it down, make sure that you have all this information that can be articulated at the appointment, because those are really important items that we're going to need to know about.
Yeah, and so these are all the people that we have to communicate with in order to make sure we have a full picture of what's going on with the patient. So the include me is the patient, right? They should always be at the top of the list, right? We should always be directly communicating. If you are going to appointments and you're not seeing other providers directly communicating with the patient, encourage it. It's a new experience for some of our families, but it's really important for the patient to be at the top of that list, and also for our DSPs. They don't always make sure that people speak directly to the patient, but also obviously the staff are going to be really important. So there's lots of, again, apps for monitoring, you know, and making sure that we have, at least in New Jersey, a lot of laws that say how we need to communicate with our families, right? There's Camino's law and there's Danielle's law, and all of those things are tools to make sure that we have the family included in the resources. But then we equally need to know the number of specialists, and did they go to urgent care or the emergency room as a result of Danielle's law? Because we understand that these residential facilities do need to access these other sources of care in emergencies, but we equally need to know about them as the primary care doctor, because a lot of times that can fragment continuity, and we kind of want to make sure that we keep all the pieces glued together. I will tell you that the reality, and when we look at this from a research perspective, we just don't have good tools. And this is data that came out in 2022. I will tell you, in the US, compared to other countries, we just don't have really good tools that are helping us share information. And that's also true from New Jersey, right?
Yep.
So some of our parent advocacy groups are hoping that we can get a tool that helps us know where we can get information about bowel movements and sleep and medication changes, and when we saw the specialist in one place so that we are communicating a little bit better with each other. The reality is when we really look at it, we don't have it yet, but we're willing to sit at the table with you and say we need it and we want it so that we can all provide the best care for our patients. There are a couple of resources out there already. One's called the Nuts and Bolts of Healthcare that do already help us get to there. Probably can answer what is risen pretty quickly too. Here's the reality. I think we're just about at the end, and we'll tell you what risen is. The reality of what we do as primary care doctors is really promote wellness, right? So we really want our patients to get the same wellness care that their mom, dad, brother, sister, neighbor get. And a lot of that time, that is just access to routine preventative care. And when they don't, and we can't bridge the gaps, they actually unfortunately get sicker more often and need more care. So we want everyone to know that they can err on the side that patients can get that access. We just have to get it to them in the way that they need to do it. So that's how we can get to better self-management. Because we have about 15 or 13 minutes.
So real quick, let's answer what is Risen Center, because we've been talking about Risen, assuming that everyone knows what Risen Center is, and didn't take the time at the beginning to articulate that. So Risen Center stands for, okay, ready? Rowan Virtua. So Dr. LeCompte and I work for Rowan University School of Osteopathic Medicine, which is a medical school in Southern New Jersey for those Northern New Jersey people who are on the call. And we have an affiliation with a hospital system down here called Virtua Health. So it's Rowan Virtua, regional, that's the R, integrated, that's the I, special needs center. So that's the Risen, Regional Integrated Special Needs Center. And we just had our 5-year anniversary. Started in April of 2019 and then COVID. Yeah, so we service the lower 7 counties. So if you kind of drew a line across New Jersey from Burlington County down, those are our counties that we service, which is the regional component in our title. So that's what Risen Center is. We do primary care. It's a primary care office. We do have some behavioral health supports embedded within our practice. We've got social work. We've got some other, I can't talk about other people that we're bringing on, but we've got some other support staff that are really important in the holistic care of special needs individuals that are going to be joining us in the near future as well. So so that's what we are.
Yeah, and so what's challenging sometimes, because we have those behavioral supports, some people try to access our practice exclusively for those behavioral health supports, but we are a primary care practice. At our core, we accept new patients who need a new primary care doctor, and then those other supports. And we recognize that many people can benefit from those supports. We take care of people with intellectual, developmental, and physical disabilities with a childhood onset condition. We recognize that people with traumatic brain injury as an adult or stroke and everything would also benefit from that model. But we really try to focus on that IDD population or childhood complex childhood onset conditions as they get here. That does mean that some of our patients get here later on in life, especially as they join some of the residential facilities in this area. And that's challenging too, because they never had the transition model beforehand. I mean, that's just the reality. Not everyone had that transition model. But it's also important to note that we are a medical school and a teaching school. So you'll see learners in our offices with us, and they'll be coming in so that we're modeling the behavior that we're hopeful that you'll all receive after they leave our school when they're developing their own practices. So you'll see a lot of learners in that, and a lot more learners coming too.
So we have medical students who are here doing some rotations with us. We have residents who see patients with us. And this is part of our mission as well, is to educate the medical community at large in how to care for special needs individuals. So the hope is that they're going to move forward and eventually become practicing doctors in whatever specialties, but they'll have an appreciation for what it takes to care for this population, and they'll understand the accommodations that are necessary to provide the best care. And so that's what we're doing. And we're already seeing students who've been working with us saying, you know, I want to be like you guys. I want to be at Risen Center one day. I want to work here. This is a great place. So there were some questions about, are there Risen Centers elsewhere? And we don't currently have any satellite offices later this year down again in Southern New Jersey. But it looks like some people are sharing with some other practices that are further north that they've been very happy with. So
yeah, we're even having some students coming from other systems.
Yeah.
So we actually have a student currently who's coming from Rutgers. So and she is sharing with us some of the other resources that there might be up there. And certainly our partnership with Virtua likely will help us expand our mission and values into some of the other practices that are more up north, because that's largely where Virtua has been serving currently. And so I think that there's going to be an opportunity, and certainly part of our teaching opportunity is not only to teach students, but teach other providers who are already practicing, that we're a resource for them. And so we do welcome that. We're hoping that we can build that into our model also, so that if you are already with a great medical home and you just, you know, the provider's just scratching their head, reach out to us. You know, we'd love to educate more providers on access to reproductive health care, desensitization for labs, like what you said. I will tell you that ABA and support services in the home can absolutely do this work. And we're starting to communicate with some of our partners. We've been talking about it with our Autism New Jersey consortium, and how do we make sure that people know what resources they can advocate for that get them better health care access. So we're still working on that, and we wish everyone could come here. But certainly if you have an ear infection and you have to travel 2 hours to get here, it's not ideal. It's not getting care in your medical neighborhood, and we want our patients with different abilities to be able to access care everywhere, including in the emergency rooms, which we know can be exceptionally challenging and disruptive to our continuity of care.
To your point, Kathy, we're working on educating existing physicians as well as up and coming physicians as well. Yeah.
So you know, some of the opportunities that we hope that our DSPs and our group homes really take advantage of is providing education for their patients on becoming better self-advocates. I think that one of the opportunities that we don't usually take advantage of when we have home health aides in our homes, and having them sitting next to the patient, teaching them how to be their own self-advocate all the time that they have. Equally, I think our opportunity is when they're in residential facilities, teaching some of these life skills so that our patients can call the doctor's office themselves one time and really be proud. I used to do this in my practice in Delaware, and we would celebrate that win when we got a call from a patient directly and making their own appointment. Here's the good news. Sometimes it doesn't even have to be talking to us, right? We have so many technologies now where you can just type it in. And I know our patients are capable of doing some of this with support. That's why supported decision-making is so wonderful. And using some of the downtime in our residential time to really help patients check off the list of being their own advocate, not just from moving from pediatric to adult care, but just actually hitting the reorder button for their medications, filling up their med boxes, really participating in the care at the level that they would in their own home, but with the support of anyone in the residential facility. And I know that's and thanks, Melissa. Yes, empowering them to do what they can do, and then celebrating it when they do. Because listen, we cheer in the hallways sometimes when someone gets their first vaccine without needing sedation. Right? I mean, we're trying to do the least restrictive model of care for any one of our patients, but sometimes that just takes more time, and empowering our residential facilities to use that time, just like we send them home with PT, with home exercises, right? Making sure that that happens in their group homes
The
once
little
they
wings.
get.
The little ones, like my son cognitively is about age 3, and I forgot he has significant epilepsy. I forgot to give him his meds the other morning. And it was like 11:30 in the morning, and he was like, Mommy, I need we call his medicine vitamins because it sounds, I don't know, it sounds better to him that way. He's, Mommy, I need my vitamins. I was like, oh my gosh, it's 11:30. We're like 4 hours overdue. And we're like, oh my gosh, he knew that I forgot his vitamins. That's awesome. So little things like that are what we're talking about.
So I think we're about at the end of our time, but I think that the World Down Syndrome model of assuming that I can, so maybe I will, should be a model both for DSPs and residential facilities, like assuming that they can and they will, assuming that doctors will hear you too, because I recognize that we don't always, and then assuming that our patients are absolutely able and can and will, you know, be able to be healthier so that they can thrive in the community. I hope that's what you wanted, Melanie.
Absolutely.
And like all kinds of great comments. It's been almost like a little bit distracting because we're trying to like talk and look at our slides, and I'm trying to look at the comments too. And some of these comments are really wonderful and phenomenal and collaborative. And thank you guys for giving your 2 cents and your wins and your frustrations.
I agree. I think the chat section alone, right? We could take those questions and do a whole, and I won't do that to you both. But we could take those questions and do a whole nother webinar off of some of those,
we would be happy to do that,
input
actually.
and concerns. But it's right, it's the lived experience that we all have as professionals, as family members, as support professionals that really allow us to guide others who are seeking information, and we're learning from each other during sessions such as this. I think one of the things when Dr. LeCompte, Dr. Iannizelli, when I initially reached out, my son does live in a provider managed setting. His direct support professionals do support him during his medical appointments. And my husband and I do the best that we can with our schedules to make sure that we are able to join him during those appointments. We feel that that's really important, but sometimes it's just not possible for some families. And we've even, when we haven't been able to attend, right, have written down some of our concerns, some of the questions that we have, some of the topics that we know may be upsetting to my son to be discussed out loud in front of him. And we've written those down and we've given that to his direct support professionals, and they've handed that in, right? So that those questions could be addressed, that our voice was still being heard. Some of the things that we're noticing in our environment when he's home with us is very different than those situations that they're noticing when they're in the community with him, when they're at the home with him. So I think, again, right, that collaborative approach really allows for a full picture to be given to the medical professionals who are providing that guidance to that individual. So I thank you both for taking the time to share your expertise with us. We have a ton of questions. I want to make sure there was one that came in earlier. Let me just read that real quick because we had a lot of comments, follow-up comments to that one question that came in. So I apologize. Let me just find this. And every time a question comes in, it sort of scrolls back down.
I know, that happened to us. So that's why we got distracted a little bit. We were trying to keep up with the comments so that that wouldn't happen.
Absolutely. So it came in, here we go. A major issue that we've encountered is following through to get medical tests prescribed by physicians. For example, we have been unable to find a facility that will do I'm assuming gynecology exam or CT scan under general anesthesia. And this is needed due to someone's anxiety and related behaviors.
Yep.
Has anyone had a positive experience in this regards? Do either of you have any suggestions for this family?
Yeah. So we have the same problem, but we are really working hard to partner with local hospital systems, not just Virtua, who we're affiliated with, but all the local hospital systems in our area, to educate them on why this is needed. Dental care is another under sedation procedure that is that's always tough to find. But we're hoping that by collaborating with local hospital systems, and that's been working really well so far, that we're slowly but surely getting there. For example, Cooper Health System is in our area. We had someone who went there recently for a GYN exam and had blood work done at the same time. Yay. We had someone who's had an MRI done and blood work done at the same time at Virtua. That was awesome. So I feel like
Yeah.
and once the hospital systems start doing this, like it's a lot of work to get those first few cases coordinated, but once we do, and the anesthesia department becomes more comfortable and they meet us and we meet them and they understand, like, okay, here's Dr. Andy and Dr. Lacombe's cell numbers. We can just like text them if we have a question. It's starting to work much better, and they're, I think, truly starting to become part of the team. So I think that's our solution, is having primary care docs like Dr. Lacombe and myself who are willing to go that extra mile and educate the local hospital systems and work with their specialty teams, their radiology departments, their dentists, their anesthesiologists.
Yeah,
et cetera.
and we found partners like dentists who are already bringing our patients under sedation, and then calling in advance and doing these other reproductive health exams, lab draws, access to vaccines under sedation, so that we're not sedating people multiple times. Because definitely we're still trying to get to the least restrictive, but listen, there are some neurotypical patients who need to be sedated for some access points, and it's not exclusive to people with different abilities. Sometimes we think it is, it really isn't. And I think that part of the design of how we deliver access to care for neurodiverse patients or patients with different abilities is setting up stages for people who need it. Listen, all women need a better approach to reproductive health care that isn't so scary, that we don't just drop them into a cold speculum and not educate them about what's coming up. So because we designed that for people with different abilities, bringing that out to the schools. And we recognize that sometimes it's just about, when we create accommodations for people with different abilities, it actually gives better access to our neurotypical patient population. Like, we have adjustable beds. Our weekend warriors benefit from that when their knee goes out. Our geriatrics patients benefit for that because they can't climb up on our medical tables, and our toddlers benefit from that, and our babies don't fall off beds because we bring them down to the lowest. So we use them for everyone now, and so it's kind of like clearing the ramp first before we clear the stairs, so that people can get in the door and everyone can use that same access. So it's about finding those pieces where you're already using sedation and then getting access in the back door for these other ones. That's the approach that we've taken so far.
Wonderful. And please, everyone, keep scrolling through those chat sections. I see some wonderful resources coming in from other professionals and families. Again, right, we learn from each other. So scroll through that chat section. Dr. Lacombe, Dr. Iannuzelli, do you have a few more minutes for a couple of questions?
We can take them, yep.
Great. So let's see, it says, can you please, you may have already touched on this, please address the issue of physician practices being unwilling to accept patients with Medicaid, even if that Medicaid coverage is secondary. Any Medicaid, Medicare issues that you could help families address? We do hear that families are having a challenging time finding primary care or specialty care doctors willing to accept.
So I think we need to start using the terminology discrimination, because that's what that is. And fortunately, at least NIH is starting to understand that. NIH is how we kind of research these topics, right? So I will tell you, just even from systems-based care. We haven't been able to address this in a research-based manner yet until they actually identify people with disabilities as a marginalized patient population.
Which we're working on.
Yes. And so there are now, we're using the term ableism, which is discrimination against people with disabilities, basically, for any reason to access care. And I think we need to start using that terminology with some of our healthcare providers and systems of care, because it is discrimination.
Spade is spade.
Yeah.
But to answer your question of do we have any suggestions? We can't at this stage of the game. We can't force doctors to accept particular insurances. Right now, they can still cherry pick which ones they want to subscribe to and which plans they don't want to participate in. But if you're having difficulty finding someone who will provide care for your loved one, you should have, if you've got Medicaid, New Jersey Medicaid, you should have a nurse navigator that, at least I know for our family, as soon as we subscribed, we got the name of this amazing person, and she's our nurse navigator. And whenever we have a hard time finding a specialist, we call her and she's like, oh, okay, you need a dermatologist who, will wait until your kids sit still so they can examine their skin, or wait until they're willing to take off their shirt, and she has been wonderful at helping us find resources. So that's what I would recommend if you're having a difficult time finding someone who will accept your kids' insurance, is call the insurance company and talk to the nurse navigator. But in a perfect world, our vision is that the state requires everyone to accept Medicare. And Medicaid rather, not Medicare, but Medicaid. Well, both.
Yeah, but I will say one of the challenges for the healthcare systems is basically how the healthcare system credentials physicians, and they do credential some folks for just a certain number of insurance. Now, if you're not credentialed with that insurance, then you can't accept patients. So if you don't put an application in, and the reality is we don't decide which insurances our system decides to credential us for. So Rowan Virtua has a list of folks that they credential under, and so that doesn't include everyone. I will say that. I know that there's some insurances that our system doesn't credential us under, not by our choice, just in case. And I'm probably not by a lot of doctors' choice. If you're part of a system, it's the system that's deciding what insurances you're going to take. If you're more private, then again, you can kind of cherry pick what you want to apply for and not apply for. So that's where it limits. And then, we do know that our families are then paying some of these out-of-pocket services. We're trying to actually investigate how do we use our DDD budgets to access care when it isn't covered by insurance, right? So we're still learning too about those. And maybe I can add that to your list, Melanie, of like, how do we use our DDD budget to our fullest, including accessing some of these medical services?
Well, as I'm going through this chat, well, number one, you have a lot of fans, but also we have people saying that they're hoping that there is another seminar similar to this. So I may bother you both in the future.
Happy to do it.
Possibly just to have another open conversation, right? Because we have so many questions coming in. Families just need to know, and they're not sure who to turn to for this information. Can you also give some suggestions or what your opinion would be? Someone suggested that it's easier to choose a primary care physician and specialist from the same hospital system. Someone wants to know, should they choose a PCP from a hospital system? And how do they find a PCP who is specific to addressing people with special needs?
That's a loaded. So it's a two-part question, right? So the first question is, should you find a PCP who's affiliated with a particular hospital system? And that's a loaded question. Because although I would love to, and Dr. LeCompte may have a different answer than I, so this is just this is not her opinion. as much as I would love to say, no, you can choose whoever you feel is best for your family, best for your loved one. The reality is that it is easier in New Jersey's current system of care to stay within one particular system. So we're with a medical school. We have an affiliation with Virtua, which is only a recent thing. So for the first 4 years of Risen's existence, there was no affiliation with any hospital system. And so we were one of those like neutral territory types of practices where and now we have an affiliation with Virtua. It doesn't mean we always send our patients to Virtua for everything, because we really don't. I feel like we're equal opportunity. We
Yes.
go wherever we feel our patients would be served best. And that's really, I think we stick to that.
Yeah, and sometimes that's because we have a good relationship with, and have already had good experiences with some of the specialists. We know that they'll respond to us when we have a concern about our patient. And so if we know that we're going to get a better response, then we do navigate outside the systems. And again, probably we don't want this recorded, but that's what we have to say, because we have to go where our patients are going to get their best care. And so that's not always in a straight line. So there are some registries for finding physicians like us who care for people with different abilities. And quite frankly, sometimes, again, that's from the beginning of the presentation, is you can go to these family resources that I think people are very open and honest about who they found to be helpful and effective, and who hasn't. Like Autism New Jersey has lists. I will tell you, for some people who have specific genetic syndromes, there are registries. And so each of those specialty care have a list of providers who might be helpful. We've been reaching out to them too, because we know that we need them as a resource. Primary care doctors can't know everything about every rare genetic syndrome, but we're not shy about reaching out. So I think that the key is just finding a doctor who hears you and listens to you. And you guys know this from the very first appointment. I think that our patients can tell if we're, and the way your family members and the way the patients respond to the provider. I've had several great experiences where they're like, wow, this is the first time that we were able to sit through a whole appointment and get to the next level. And that really early on in an appointment, and don't be afraid to change if you need to.
Yeah. As painful as it may be.
Yeah.
Dr. LeCompte, can I ask you to forward the slide? I just want to make sure that we're getting to the contact slide.
Oh, sure. Sorry.
Your closing slides also.
This one?
Yeah, so on the screen, just so everyone knows, this is how you can reach out to the Rutgers University Community Living Education Project, again, also known as CLEP. I am going to send a copy of a PDF version of the PowerPoint, so all this will be in a follow-up email along with the recording at the end of the week. Feel free to take out your phone, take a quick screenshot if you choose to do so. If we can be of any assistance in providing any guidance or resources to your family as you're exploring community living options. And community living, right, is a really broad term. So if you need any advice or resources, feel free to reach out to us. And here is a quick link to our evaluation. As we're preparing to say goodbye, you're going to see a quick maybe 20-second eval show up on your screen. We encourage you to take those multiple choice eval. It's going to allow us to better serve the community in the future. It's the responses that you give that, again, really provides guidance to us on the information that you're looking for. And then Dr. Iannizelli, Dr. LeCompte, do you have any closing slides?
Nope,
I think
no.
that one that Dr. LeCompte showed. Oh,
yeah, you'll get some resources. Again, these are not exhaustive. I was just trying to provide, we were just trying to provide some tools that we already mentioned for transition. So there's a lot of them, but I think that, again, every time that we can share information with each other, we have got a few from this presentation from you all. So thank you for that.
Melanie, are the slides, will the participants have access to these slides?
I can share a PDF version of the PowerPoint. I want to make sure that they're not able to edit any of your content.
That's perfect.
So Perfect. Again, thank you, Dr. Iannizelli, Dr. LeCompte, thank you so much. It is always a pleasure. You are extremely patient-centered, family-centered, and as a parent, I truly appreciate your approach. We are grateful that you both took the time to share with us this afternoon. Hopefully, again, we can do it in the future. I think that this
That'd be
was a
fun.
really well-received session. So thank you so much. And thank you to everyone who
Madeline.
joined us today.
Yeah, thanks everyone for taking your time. Oh my gosh, this was it's wonderful when we see that people really care.
Yeah.
So we appreciate that.
Please be well, everyone. Thank you again, and we hope to connect with you all soon. Have a great day.
Take care. You too.
Yeah.
Bye.